You can sit on a plane for half a day, get off feeling just fine, and still be carrying a clot in your leg that can travel up to your lungs without giving you any warning first. Roughly half of all deep vein clots produce barely any clear symptoms, and that is exactly why doctors sometimes call them a silent killer. And this is not only a worry for people in their 80s in nursing homes. These clots are turning up in folks in their 30s and 40s who work at a desk, fly often, and consider themselves more or less healthy. Here on Dr. Waterling, my whole job is to break the science down so you know what to look out for and what to bring up with your doctor. Not to frighten you, but to put you back in the driver's seat. If you want straight health explanations without the drama, hit subscribe and tap like. The target is 300,000 subscribers, and every single click really does help us get there. If you enjoy having handy checklists and reminders, scan the QR code on the screen and you will arrive at my Telegram channel where I drop short, useful health checklists. Let us begin with what a clot inside a vein actually is. Your blood carries cells and proteins that can quickly form a plug whenever there is a real wound, so you do not bleed out from a cut. That plug is built from a protein web called fibrin, together with red cells and platelets, and in the right spot at the right moment, it saves your life. The trouble is that the same system can fire up inside a deep vein in your leg when there is no cut at all, and at that point the once helpful plug turns into a dangerous blockage. To see why this tends to occur in the legs and not in every blood vessel, you need a quick picture of arteries versus veins. Arteries are the high-pressure pipes that move blood away from the heart, and the flow there is fast and forceful, so clots have a tougher time sticking to the wall unless the artery is already roughed up by plaque. Veins are the low-pressure return lines that carry blood back to the heart, and in your legs, that blood has to travel upward against gravity for a distance of several feet. Because the pressure is low and the trip is long, veins lean on two tricks: tiny one-way valves on the inside, and your muscles squeezing them like a pump every time you flex your ankles and calves. There is a well-known idea called Virchow's Triad, which is just a fancy way of saying 3 things make a clot more likely: slow blood flow, damage to the vein wall, and blood that clots more easily than normal. Long stretches of sitting or lying still slow the flow. Surgery or trauma can irritate or injure the inner lining, and things like cancer, pregnancy, hormone pills, or inherited clotting tendencies can make the blood itself more, quote, sticky. When more than one of these shows up at the same time, your risk does not just add up, it multiplies. There is a pattern in medical records that shows how this plays out in everyday life. A man in his late 30s, no smoking, regular trips to the gym, flies home from a beach vacation in economy class, sits almost the entire flight, sips very little water, then collapses suddenly in the airport without any warning signs in the days before. On exam, doctors find a large clot in a lung artery, and later scans show that the original clot started in a deep leg vein and broke loose during or right after the flight. That is a textbook case of travel-related venous thrombosis, sometimes labeled economy class syndrome. When a clot forms in a deep leg vein, that is called deep vein thrombosis, or DVT for short. If part of that clot snaps off and rides the blood flow into the lungs, it can plug a pulmonary artery, which is called a pulmonary embolism. Pulmonary embolism is one of the major preventable causes of sudden death, especially in people who already battle cancer or other serious illnesses, even though overall treatment has improved over recent decades. One of the trickiest things about DVT is that you often do not feel much from it. Research and large reviews show that around half of people with a leg DVT have few or no obvious symptoms, and the first hint may be trouble breathing once the clot has already reached the lungs. That is why pain alone is not a reliable alarm system. Now let us tackle a few common myths head on. Myth 1 is, if there is a clot, my leg will hurt so badly that I will definitely know. In reality, many people with a confirmed DVT report only a sense of heaviness, a mild ache, or a feeling that the leg is tighter by the end of the day, and they pin it on walking, a long shift, or new shoes. Myth 2 is you can feel the clot under your fingers. The dangerous clots that lead to lung emboli usually sit in the deep veins that run between the muscles, not in the small surface veins you can see and touch under the skin, so you cannot poke around and find them like a lump. Myth 3 is only older, bed-bound people get this. While age and being stuck in bed absolutely raise the risk, modern data show that long stretches of sitting, long-haul travel, obesity, hormone therapy, and smoking push the risk up in much younger adults than most people expect. So what can you actually notice on your own? The first big clue is a side-to-side difference. If both legs swell in a similar way, same size, same timing, doctors think first about more global issues like heart failure, kidney problems, or low thyroid, which can cause fluid to build up in both legs at the same time. If one calf or one whole leg suddenly looks clearly larger than the other, feels heavier, and that gap does not melt away after a night of rest, that fits much better with a clot blocking a single deep vein on that side. The second clue is the color and the feel of the skin. When the issue is a skin infection like cellulitis, the leg tends to look bright red, feel hot, and have a sharp border where the redness ends. And pressing on the skin hurts right where you press. When you simply strain a muscle, the pain stays in a specific spot. It worsens when that muscle works, and the skin looks normal. With a deep vein clot, the leg can look pale or bluish, the veins may appear more filled, and the pain feels more like deep pressure from inside, not a stabbing pain on the surface. People often describe it as if the leg is being pumped full of air or fluid from within, and no position fully takes it away. Third, there are classic bedside maneuvers doctors have leaned on for decades to raise or lower their suspicion, but you have to understand their limits. One is called the Homan sign, which means straightening the knee and then pulling the toes toward the shin to stretch the calf, looking for sharp pain deep inside the calf. Studies show this sign on its own misses many cases and is wrong in others. Its sensitivity and specificity are low, with wide ranges across different studies, so a positive sign does not prove a clot and a negative sign does not rule it out. Another older maneuver is sometimes called the Moses test, where squeezing the calf from front to back produces more pain than squeezing from side to side, because the deep veins run in that front to back plane. Again, this can back up a doctor's clinical impression, but it is not a standalone test, and modern guidelines rely much more on proper imaging and blood work than on these signs. So what should you do if you have a one-sided, swollen, heavy leg, and maybe those stretches clearly bring up deep pain in the calf? What you should not do is massage the leg, dunk it in a hot bath, or sit in a sauna to quote-unquote improve circulation, because heat can widen vessels and, in theory, help a loose piece of clot travel. In medical practice, a common approach when doctors strongly suspect a DVT is gentle, even compression with a bandage or a medical compression stocking, and then quick imaging, not aggressive rubbing or heating. For you at home, this is exactly the kind of situation where heading to an emergency department or urgent care for same-day evaluation is worth it, and it is something you can and should talk through with your own doctor ahead of time if you know you are high risk. In the clinic or hospital, the main workhorse test for leg clots is ultrasound of the leg veins with compression, called duplex ultrasound. The idea is simple. The person doing the scan presses the probe down over each vein. A normal vein collapses flat with gentle pressure, but a vein packed with clot stays round and firm, which tells the doctor that segment is blocked. Because it is non-invasive and uses no radiation, this test is the standard first step in most places when a DVT is suspected. There is also a blood test you hear about a lot called D-dimer. D-dimer is a small fragment of the fibrin mesh that shows up in the blood when your body is in the middle of breaking down a clot. So high levels mean your clotting and clot clearing systems are busy. Large studies show that a normal D-dimer in someone with low or moderate clinical suspicion makes an active clot very unlikely. The negative predictive value is high, which is why emergency doctors use it to safely rule out venous clots in many people. But the flip side is that plenty of things besides DVT raise D-dimer, including infections, recent surgery, pregnancy, cancer, older age, and even hard exercise. So a high result by itself does not prove a clot, and always has to be paired with imaging and clinical judgment. For that reason, running this test just to check when you have no symptoms can backfire, because an unrelated high result may just spike your anxiety and lead to more testing you did not really need. If imaging confirms that you do have a DVT, treatment depends on where the clot is, how big it is, and what your overall risk profile looks like. The backbone of therapy is anticoagulation, meaning medicines that make the blood less able to form new clots and stop the existing clot from growing while your body slowly chews it down. These can be given as shots under the skin like low molecular weight heparin, or as pills such as older drugs like warfarin or newer direct oral anticoagulants. And large reviews show that all of them work by tipping the balance away from new clot formation. They do not magically dissolve the clot overnight. They steady the situation so your own fibrin clearing system has time to do its work, which can take weeks to months. Choice of drug and dose has to take into account your kidney function, weight, other medicines, and bleeding risk, which is why this is always a shared decision with a qualified clinician, not something to self-start based on a video. In more severe cases, for example, a large free-floating clot in a main thigh or pelvic vein, or a massive pulmonary embolism with low blood pressure, hospital teams may bring in more aggressive options. These can include clot-dissolving drugs given through an IV, catheter procedures to physically break the clot apart, or in some situations, placing a filter in the main vein that returns blood from the lower body to the heart, called an inferior vena cava filter. That filter looks like a small metal umbrella that traps large clot fragments before they reach the lungs. And evidence shows it can be life-saving in people who either cannot take blood thinners or keep forming clots despite them, though it has its own risks and is not used casually. Now let us pull back to how clots get going in the first place in everyday life, because that is where you actually have leverage. Long flights are a perfect storm. Cramped seats, bent knees, low cabin humidity, and often coffee or wine instead of water. Research on so-called economy class syndrome shows that periods of sitting still for 4 or more hours, especially in people who already carry risk factors, clearly bump up the chance of DVT and pulmonary embolism. In case control studies, recent long travel multiplied clot risk several times compared with people who had not traveled, which lines up with what doctors see in practice. From the legs' point of view, your calf muscles are your second heart. They sit inside a tight wrapping of connective tissue, so when you walk and the muscle bulges, the pressure inside that compartment rises and squeezes the deep veins, pushing blood upward toward the heart with each step. When you sit at a desk or in an airplane seat for hour after hour, that pump shuts off, blood flow slows, and the small one-way valves have to work harder. Which is why people with sedentary jobs often spot sock marks and heavy legs by the evening. Simple movement breaks make a real difference here. Studies and expert reviews on travel-related clots suggest standing up and walking the aisle every hour or so on long flights, doing ankle circles and calf squeezes in your seat, and steering clear of tight clothing that digs into the groin or behind the knee. Staying hydrated with plain water and easing off on alcohol and caffeine on these trips helps keep your blood from becoming more concentrated, which also lowers risk. Many guidelines recommend graduated compression stockings for people with extra risk during long travel. But the level of compression and the fit matter, and getting those choices right with a clinician or vein specialist is worth it if you are unsure. For people at very high risk, for example, with a recent major DVT, active cancer, or strong inherited clotting tendencies, some specialists give a single preventive shot of low molecular weight heparin before a long flight or after surgery, because this kind of anticoagulant targets the clotting factors that drive venous thrombosis. That is absolutely not something to copy on your own, but it is very much the kind of measure you can ask your doctor about if you know you sit in a higher risk group. Let us talk about varicose veins, because people often dismiss them as just cosmetic, but from a clot point of view, they are much more than that. Varicose veins are surface veins that have stretched out and become twisted because their valves are damaged. so blood can slide backward instead of moving steadily upward. That backward flow raises pressure, widens the vein even more, and sets up pockets of slow, swirling blood, which is exactly the environment that favors clot formation. Creams and gels with plant extracts may ease that feeling of heaviness for a little while, but they do not fix broken valves or tighten floppy vein walls. Modern vein care has shifted toward minimally invasive fixes. Procedures such as endovenous laser ablation, radiofrequency ablation, or foam sclerotherapy shut down the worst surface veins from the inside so that blood reroutes through healthy, deeper veins. And these treatments are often done under local anesthesia with quick recovery times. Studies show that when used for the right patients, these approaches reduce symptoms and lower the risk of repeated surface clots in those damaged veins, which indirectly helps the whole system run better. Whether and when to treat varicose veins is another decision to make with a vascular surgeon or vein specialist. But the core point is that just living with them forever is not always the safest long-term plan. Now, a word about aspirin, because you hear about it nonstop. Aspirin is an antiplatelet drug, which means it mainly stops tiny blood cells called platelets from clumping, and that is why it is used so heavily to prevent heart attacks and certain kinds of strokes where clots in arteries are the main issue. Deep vein thrombosis is driven more by the clotting proteins in plasma than by platelets alone, so standard treatment and prevention rely on anticoagulants that act on those proteins, not on aspirin by itself. Large reviews and guidelines do not list aspirin alone as a primary tool to prevent travel-related DVT, and long-term aspirin use carries its own costs, like a higher chance of stomach bleeding, especially when taken without clear medical need. So the popular idea of popping an aspirin before a flight to thin the blood is something to be very skeptical about, and if you are considering it, something to run past a doctor who knows your history instead of doing it out of habit. Age also shifts the picture in a way that is easy to underestimate. As people move into their 40s and 50s and beyond, vein walls lose some tone, valves can fail more easily, and recovery from long days of sitting gets slower, which all nudges the risk of DVT upward, even if lifestyle stays the same. At the same time, pain perception and what feels like a normal baseline shift with age, so an older person may shrug off symptoms that a younger person would find alarming. For that reason, I want you to really think about this. How old are you? And does that line up with how seriously you take these leg and travel symptoms? Age is not destiny, but it does shape your personal risk level, and knowing where you stand lets you have a sharper conversation with your doctor instead of a generic one. There is also a pattern doctors see over and over in office practice that shows how easy it is to miss this. Someone like Mike, early 40s, slightly overweight, works at a computer all day, drives home in a car, watches shows on the couch at night, and does almost no regular leg-heavy movement. He notices that by evening, one calf looks puffier and his sock leaves a deeper groove, but there is no sharp pain, so he decides it is probably a pulled muscle and waits a week. When he finally comes in because the leg now looks clearly larger and the skin is a different color, ultrasound shows a sizable DVT that has been building quietly, and everyone wishes the alarm bells had rung sooner. So let me boil this down into a simple mental checklist you can carry in your head. If one leg suddenly looks and feels different from the other, heavier, more swollen, a different color, that is not something to watch for a week to see what happens. If simple calf stretches like pulling your toes toward you bring on deep, unfamiliar pain on that one side, especially after travel or illness, that is another reason not to brush it off, even though those signs are not perfect tests. If a doctor suggests only a D-dimer without ultrasound and it comes back a bit high, remember that this is a non-specific signal and ask calmly about the whole picture, your symptoms, your risk factors, and whether imaging is needed, instead of panicking over the number alone. Now, what are the everyday, boring habits that actually protect you? At work, set a timer to stand up at least once an hour, walk over to refill your water or hit the restroom, and while you are on calls, do slow heel-to-toe rocking to keep your calf pump active, even if you cannot leave your desk. In the evening, lying on your back with your legs propped on a pillow or against the wall for 15 or 20 minutes lets gravity help drain the veins and can ease that end-of-day heaviness many people feel. If you know you have surgery, pregnancy, or a long hospital stay coming up, talk ahead of time with your team about which DVT prevention plan they use. That might include early walking, compression devices, and timed doses of anticoagulants while you are less mobile. After watching this, your next steps are pretty clear. First, pay closer attention to your own baseline, what your legs normally look and feel like, how they change with long sitting, and whether one side is clearly different from the other. Second, take a look at your routine travel and sitting habits and pick specific changes, like hourly movement breaks and serious hydration on long trips that you can actually stick with, not just think about. Third, if you carry risk factors like a prior clot, active cancer, strong family history, major varicose veins, or hormone therapy, raise venous thrombosis directly with your doctor and ask what preventative plan makes sense for you instead of waiting for someone else to bring it up. Everything I have just walked you through is here to help you ask sharper questions and catch red flags sooner. But it is still general education, not a custom medical plan. So always take this kind of information to a clinician who knows your full story before you change anything important. If this gave you a clearer picture of how clots really behave, subscribe and tap like so Dr. Waterling can hit that goal of 300,000 people who truly understand their own bodies. For short, practical health checklists that build on what you just heard, scan the QR code on screen and join me over on the Telegram channel.